Welcome back to PCA Deep Dive. Today we start with a phrase that sounds fictional, the Committee on Quackery. It wasn't satire, it was real. In 1963, the American Medical Association launched a formal campaign described in federal court records with two words, containment and elimination. The target was an entire profession. The explicit boycott ended in 1987. The barriers did not. They evolved, from prohibition to payment design, from closed doors to copays, from committees to spreadsheets. This is the story of how access is engineered. Let's begin.
I want to start today with a phrase that, honestly, it sounds like it was pulled directly from a satirist's notebook.
It really does.
It sounds like something from a rejected Monty Python sketch, or maybe a conspiracy theory about some kind of secret society.
Right. You picture men in, dark robes chanting in a basement somewhere.
Exactly. The phrase is the Committee on Quackery.
It does have a certain dramatic flair to it, doesn't it?
It sounds completely absurd. It sounds like a joke. But, and this is really the hook for today's deep dive, it was very, very real.
Not a joke at all.
No, it was a formal department established in 1963 by the American Medical Association, the AMA. And despite that almost goofy name, their internal documents described their mission in language that was anything but funny. They used military terminology.
Containment and elimination.
That is just a chilling phrase when you apply it to a profession. Containment and elimination.
It is. And to be crystal clear for everyone listening, we are not editorializing here. We're not adding our own dramatic flair. That specific phrase, containment and elimination, that comes directly from federal court records.
And the target of this containment was the entire chiropractic profession.
The entire profession.
So today we are going to tell a story that feels like two completely different movies stitched together. The first half is, it's a literal legal thriller. It has spies, it has infiltrations, it has a whistleblower with the codename Sore Throat.
You can't make this stuff.
I can't. And it all culminates in this massive antitrust lawsuit called Wilk v. AMA.
But the second half of this story is actually the more important one, I think, for anyone trying to navigate the healthcare system today.
Absolutely.
Because the Committee on Quackery is gone, the explicit ban on chiropractors is over, but we need to answer a much more fundamental question. How do you stop a patient from seeing a doctor?
Right. And back in 1963, the answer was pretty straightforward. You ban the doctor.
You ban them.
You threaten the hospital. You engage in what we're going to call explicit barriers.
Precisely. Men in a room making a rule. But today, you don't really need a ban. You have spreadsheets.
The spreadsheets.
You have what we call vertical integration and benefit design. We've moved from an era of explicit barriers to an era of implicit barriers, an economic architecture that steers patients just as effectively, but much, much more quietly.
So we are going from a conspiracy to a spreadsheet.
That is the journey we're taking today, from the Wilk antitrust case all the way to the modern corporate balance sheet.
Okay, let's start with the thriller. We need to set the scene. It's the late 1950s, early 1960s. Where does chiropractic even stand in the American medical landscape at this point? Is it just a fringe movement?
It was definitely fringe, but it was a growing fringe.
Yeah.
And that was the problem for the medical establishment. If it had stayed completely on the margins, just a handful of practitioners here and there, the AMA probably would have just ignored it.
Yeah.
But by the late 50s, chiropractors were getting organized. They were successfully lobbying for licensure.
So they were gaining legitimacy.
State by state, they were getting licensed. They were seeing patients. And the medical establishment, specifically the Iowa State Medical Society, decided that a passive approach, just ignoring them and hoping they'd go away, wasn't working.
Wait, Iowa? That feels like such a random place for this huge medical war to kick off.
Iowa was ground zero. It really was the test lab for this whole strategy.
Yeah.
The legal counsel for the Iowa Medical Society was a man named Robert Throckmorton.
Okay.
In the narrative of this deep dive, he is essentially the chief strategist for the opposition. Throckmorton looked at the landscape and said, basically, we're fighting this all wrong.
Wrong how? What were they doing before him?
Before Throckmorton, the state medical societies would go after individual chiropractors. They try to, catch them practicing medicine without a license, or maybe sue one for malpractice individually.
A sort of piecemeal approach.
Exactly. Throckmorton argued that this was completely inefficient. It was a game of whack-a-mole. You take one down, another one just pops up.
So he proposed a fundamental change in tactics.
He drafted what became known as the Iowa Plan. And his thesis was simple, but frankly, ruthless. You don't fight the person, you fight the profession.
Wow.
You strangle the profession itself. You choke off its ability to sustain itself, to educate new members, to access basic tools.
And the AMA, the national body, they saw this plan and adopted it.
Oh, they loved it. They looked at what Throckmorton was proposing in Iowa, and they hired him. They took the Iowa plan, and they rolled it out nationally in 1963.
And that's the birth of the Committee on Quackery.
That is the exact moment.
Yeah.
And the strategy was, from a certain point of view, brilliant. Because it didn't just run ads saying chiropractors are bad. They went after the infrastructure of medicine. They went after the plumbing.
This is the part of the source material that really just blew my mind. They weaponized accreditation.
That was the nuclear option. To really get this, you have to understand the power of the JCAH, the Joint Commission on Accreditation of Hospitals.
JCAH.
In the 1960s, and to a large extent still today, this body is the ultimate gatekeeper. If a hospital loses its JCAH accreditation, it is a complete catastrophe.
What does that mean in practical terms?
It means they lose federal funding, Medicare, Medicaid, gone. They lose their ability to run internship and residency programs, so they can't train new doctors. They basically die as an institution.
Okay, so the JCAH holds the keys to the kingdom.
Yeah.
What did the AMA do?
They use their considerable influence to get a specific standard inserted into the JCAH rulebook. It was subtle, but it was absolutely deadly.
What did it say?
It explicitly stated that in order to be accredited, a hospital could not extend privileges to cultists.
And cultist was the operational term for chiropractor.
Explicitly. In 1966, the AMA's House of Delegates passed a formal resolution officially labeling chiropractic an unscientific cult.
That wasn't an accident. That was a strategic move.
It was a very strategic move because it triggered their own ethical code. Specifically, Section 3 of the AMA Principles of Medical Ethics at the time.
And what did that say?
Roughly paraphrased, it said, "It is unethical for a physician to associate professionally with a cultist."
This is what I really want to drill into. Unethical to associate. That sounds so vague, like don't have lunch with them. But in practice, this was a career ender for any medical doctor, any MD who crossed that line, wasn't it?
Oh, absolutely. This wasn't a social snub. This was a policy of total professional isolation. It meant you cannot accept a referral from a chiropractor.
Okay.
You cannot give them a referral. You cannot teach at their schools. You can't consult with them. And most critically, you cannot let them use your diagnostic equipment.
That's the choke point, isn't it?
That's the jugular.
Because if I'm a chiropractor and I think a patient might have, I don't know, a tumor or a fracture or some other serious pathology, I need an X-ray. I need a lab test. I need to know what's going on inside the patient to treat them safely.
And the Iowa plan was designed to ensure you couldn't get one. The goal was to make it impossible for a chiropractor to practice safely and effectively.
So they create the very danger they're claiming to protect against.
It's a self-fulfilling prophecy created by the boycott. If you can't get an X-ray, you are flying blind. And if you are flying blind, you are dangerous. It was a perfect trap.
And we have specific stories in the court records about this. The plaintiffs in the Wilk lawsuit. Let's talk about one of them, Dr. Patricia Arthur.
Dr. Patricia Arthur. A really powerful story. She was a young chiropractor in Colorado, and she was a single mother. She was just starting her practice, so she didn't have the capital to buy a full X-ray suite for her own office yet.
Which is totally normal for a startup doctor, right? I mean, X-ray machines are incredibly expensive.
Very expensive. So she did what any rational healthcare provider would do. She tried to send her patients to the local hospital, the Elizabeth Knudsen Hospital, just for imaging.
Just for a picture.
Exactly. She wasn't asking to do surgery there. She wasn't asking to admit patients. She just said, please take an X-ray of this patient's spine so I can treat them safely and rule out any red flags.
And the hospital administrator just blocked her.
He had to. The records show he told her point blank, if I accept your referral, the Joint Commission will strip our accreditation.
Wow.
So she was stuck. She couldn't practice safely without access to diagnostics.
Yeah.
And she couldn't get access to diagnostics because of the boycott. The end result, she was forced to close her practice.
That is the literal definition of containment. It's not about whether she was a good chiropractor or a bad one. It's about cutting off the supply lines.
Exactly. And it wasn't just shutting out the chiropractors. It was bullying the MDs who actually wanted to work with them. Look at the case of Dr. James Bryden in Missouri. He was a chiropractor who had developed this fantastic working relationship with a cardiologist, a Dr. Block.
A cardiologist.
A cardiologist. This is the kind of integrated care we are all screaming for today, right? The ideal model.
It is the gold standard.
They were co-managing patients. Dr. Block was handling the heart issues. Dr. Bryden was handling the musculoskeletal issues. The patients were getting the best of both worlds, coordinated care.
And then the thought police arrived.
Pretty much. The hospital ethics board intervened. They hauled Dr. Block in, and they gave him an ultimatum. Stop working with the chiropractor, or you lose your hospital privileges.
And for a cardiologist, losing hospital privileges is a death sentence for your career.
It's over. You can't admit patients. You can't do procedures. So, of course, the collaboration died.
It really highlights that this was never really about patient safety. I mean, if a cardiologist, a heart specialist, felt it was safe and beneficial to work with Dr. Bryden, that should be enough. That clinical judgment should matter.
But the bureaucracy overruled the doctor on the ground.
It was about territory.
It was strictly a restraint of trade. There's another plaintiff, Dr. Michael Pedigo, who talked about how MDs in his area would tell his former patients that chiropractors would break their necks. He had to buy all his own expensive x-ray equipment because he was completely blacklisted from local facilities.
And the AMA even went after the pipeline of new students, didn't they?
They did. They distributed what were called quack packs to high school guidance counselors all across the country.
Quack packs?
Yeah. Packets of anti-chiropractic propaganda designed to discourage smart kids from ever considering entering the field. It was a total top-to-bottom blockade designed to starve the profession out of existence.
So, okay, we have a massive coordinated conspiracy by the most powerful medical body in the country. Usually these things stay buried, backroom deals stay in the back room. How on earth did this get out?
This is where the story pivots from a legal drama to a full-on spy thriller. And I promise you I am not making this up. The code name for the whistleblower was Sore Throat.
Sore throat!
Wow.
That is a little on the nose for the Watergate era, isn't it? We've got deep throat, now we have sore throat.
It is perfectly, wonderfully 1970s. But the actual source of the leak is even stranger than the code name.
How so?
At the time, the AMA wasn't just attacking chiropractors. Their committee on quackery was going after anything they considered unscientific. And that included the Church of Scientology.
Okay, I did not see that coming.
The enemy of my enemy.
Putting my spies, that would happen.
That's what happened. The Church of Scientology, apparently seeking revenge for their own conflicts with the AMA, launched a counteroffensive.
Yeah.
It was called Operation AMA Doom.
Serious?
Seriously. They reportedly infiltrated the AMA headquarters in Chicago. They had their members get jobs inside the building as secretaries, as mail clerks, even as cleaning staff. They embedded themselves inside the organization.
They planted spies inside the American Medical Association?
Yes. And at night, or during lunch breaks, or whenever the coast was clear, they went into the file rooms and they photocopied thousands of internal documents.
Unbelievable.
And among those documents were the meeting minutes, the internal memos, everything from the Committee on Quackery.
I have to ask, is that legal? Stealing documents?
The theft of the documents.
Yeah.
Highly questionable, legally. But the documents themselves. Once they were out, they were admissible in court. And they were absolutely explosive.
Because they showed the intent.
They showed the intent. They had the containment and elimination language in black and white. They showed the coordination with the Joint Commission. He was all there. And Sore Throat, who's the insider source, mailed these documents to the chiropractic associations and to the press.
And suddenly, Dr. Chester Wilk and the other plaintiffs had their smoking gun.
They had undeniable proof of a conspiracy to restrain trade under the Sherman Antitrust Act. They filed the lawsuit in 1976.
And it was a David versus Goliath battle, I assume.
Completely. It dragged on for over a decade. Wilk v. AMA. But in the end, in 1987, the courts ruled decisively against the AMA. The judge issued a permanent injunction. The boycott was officially illegal.
So the good guys won. The explicit barrier is smashed. The no chiropractors allowed sign finally comes down.
Legally, yes. The judge even forced the AMA to publish the ruling in their own journal, JAMA, the Journal of the American Medical Association.
That must have been a satisfying moment.
A profound humiliation for the medical establishment.
But this is where the podcast usually ends, right? And they all lived happily ever after. But our whole premise today is that the explicit barrier was just phase one.
That's right. Because notice what the lawsuit didn't fix. It stopped the boycott. It didn't guarantee inclusion.
Ah, that's a key distinction.
It's a huge distinction. The court just said you can't actively conspire to destroy them. It didn't say you have to hire them or you have to pay them fairly or you have to integrate them into the system. It just ended the active war.
So what happened next? The war is over. Did the medical world suddenly open its arms and embrace them?
Slowly. I mean, very, very slowly. But we have a fascinating test case to look at what happens when you remove the hostility and the financial competition.
And that is?
The Department of Veterans Affairs, the VA.
The VA. Why is that such a good example?
The VA is unique because it's a closed-loop system. It's an employed model. The doctors don't compete for patients. They're all on the same team. They're all paid a salary. Their job is just to get the veteran better.
The incentives are aligned toward patient health, not profit.
Exactly. And starting in the early 2000s, partially because Congress mandated it, the VA started to seriously integrate chiropractic care into their hospitals and clinics.
So this is basically the control group for our experiment. What happens if you remove the trade war and just focus on the medicine?
It's the perfect control group. And the data we have is just staggering. There's a study by Lisi and Brandt that looked at the trends. Between 2004 and 2015, the utilization of chiropractic services inside the VA went up by over 800%.
800%. That's not just growth, that's an explosion.
It's a massive shift. It went from about 4,000 unique patients to over 37,000. And the number of visits went up almost 700%.
And remember, these aren't chiropractors in a strip mall down the street that the VA is just referring to.
No, that's the key. These are chiropractors working inside the VA hospital. They are co-located. They're using the same electronic health records, the EHR, as the neurosurgeons and the primary care docs and the psychologists. They're part of the team.
And the sky didn't fall, because the AMA's entire public argument for the boycott was patient safety. They claimed that if you let chiropractors into the hospital, patients would get hurt.
The sky remained firmly in place. In fact, the opposite happened. Integration became a key strategy for the VA in fighting the opioid crisis.
How so?
They found that for the younger veterans, the ones returning from Iraq and Afghanistan with chronic back pain from carrying heavy loads, having a chiropractor on the team provided a powerful non-pharmacological option. It directly reduced the reliance on pain meds.
So integration works. It works for the patient, it works for the system, it works for the providers. The evidence is there.
It works when the incentives are aligned. The VA has a single incentive: keep veterans healthy and functional for the lowest total cost. But, and here's the big pivot to the modern day, the private sector operates on a very, very different set of physics.
This brings us to the implicit barrier, the spreadsheet, what you call the architecture of access.
Let's talk for a minute about the triple aim. This is the holy grail of modern healthcare policy. Every hospital CEO, every health policy expert talks about it.
Right. Improve patient experience, improve population health, and reduce the per capita cost of care.
Exactly. Now, on paper, a service like chiropractic fits that perfectly. It's relatively low cost, it has incredibly high patient satisfaction rates, and it's effective for one of the biggest problems we have: back pain. It hits all three aims.
On paper.
On paper, yes. But in the real world, we have seen this massive shift in how healthcare is organized over the last 30 years. And the key terms are consolidation and vertical integration.
Okay, define that for us. What does vertical integration actually look like for the average person?
30 years ago, your family doctor was probably an independent business owner. They owned their own practice. The hospital was a separate entity across town. Your insurance company was a third, totally separate entity.
That's how I still picture it in my head.
But that's not the reality anymore for most people. Today, the big hospital system in town buys the doctor's practice. Then they merge with the other hospital system. Then they might buy up the surgery centers, the imaging centers, and they might even launch their own insurance plan.
So one giant corporate structure ends up owning the primary care doctor, the MRI machine, the physical therapy clinic, the surgery center, and maybe even the pharmacy.
Correct. Now, put yourself in the shoes of the chief financial officer of that giant corporation. Your job is to keep the lights on and generate a margin. Where is your revenue coming from?
Well, I would assume the big ticket items: heart surgery, orthopedic surgery, advanced imaging like MRIs and CT scans.
Exactly right. We call that downstream revenue. A visit to your primary care doctor might actually lose the system money or just break even. But that visit is incredibly valuable because it refers the patient downstream to the services the system owns.
It's the entry point to the expensive stuff.
It refers you to the MRI, which might bill $2,000, and then to the spinal fusion surgery, which might bill $50,000 or $100,000. All of that revenue stays inside the system.
I see exactly where this is going. If I go to an independent chiropractor for my back pain and they fix it with a few adjustments and some exercises,
the system loses the $2,000 MRI and the $50,000 surgery.
The patient is healthy, which is great for the patient.
But the system has lost a huge chunk of potential revenue. So the conservative care The very thing that is good for the patient and good for the triple aim is actually bad for the business in a fee-for-service environment.
So this is what you mean by economic friction. It's not that the CEO is evil and cackling in a boardroom.
No, there's no committee on quackery anymore. It's not that they are sitting there twisting a mustache like Robert Throckmorton might have been. It's that the entire system is designed, by its very financial structure, to feed the high-margin specialty centers.
And this is where we get into the modern architecture of access. The barriers aren't explicit bans anymore. They are these subtle, gentle nudges that steer you away from the independent, low-cost provider and keep you inside their high-cost ecosystem.
That's the perfect way to put it. Gentle nudges.
Give me an example of a nudge. How does a spreadsheet actually stop me from seeing a doctor I want to see?
The most obvious and powerful one is the copay, and we call this benefit design. Let's say you wake up with a stiff neck. You pull out your insurance card,
Okay.
you look at it. To see your primary care provider, your PCP, it's a $20 copay. But to see a specialist, which is where insurance plans often, and I would say arbitrarily, categorize chiropractors, it's a $60 or $75 copay.
That's a huge psychological barrier. If I'm on a budget, or even if I'm not, I'm going to the $20 door, not the $75 door.
Of course you are. It's a velvet rope. It's not a brick wall. You can cross it. It's not illegal for you to pay the $75.
Right.
But the price signal from your own insurance plan is telling you, go to the PCP.
And the PCP, who is now employed by the hospital system, refers you where?
To the hospital's own physical therapist or the hospital's own orthopedist, because that keeps the revenue, that downstream revenue we talked about, in-house.
The patient thinks they are making a free choice, but the choices have already been weighted by the benefit design. It's a channeled choice.
The architecture is doing the work. And it's so interesting, isn't it? In the Wilk era, they just told you no, flat out. In the modern era, they say yes, but.
Yes, but it will cost you 3 times as much.
Yes, but they are out of network. That's another powerful tool, network narrowing.
How does that work? How do they narrow the network?
It comes down to market power. A big, consolidated hospital system has incredible leverage. They can go to a major insurer like Blue Cross or United Healthcare and say, if you want our massive hospital system in your network and you have to have us or no one will buy your plan, you have to pay our employed doctors 200% of the Medicare rate.
And the insurer has to agree.
They have to. But an independent solo chiropractor doesn't have that leverage. They can't threaten to walk away, so the insurer turns around and offers the chiropractor rates that haven't changed since the 1990s.
You're not being serious. Literally.
In some cases, literally. Inflation goes up, your rent goes up, your staff salaries go up, but your reimbursement from the insurance company stays flat, or in some cases, it even goes down.
So eventually the chiropractor just can't afford to be in network anymore. They have to drop out.
They're forced to drop out. And now, if you, the patient, want to see that chiropractor, you have to pay the full cost out of your own pocket. You have to go out of network.
So the network naturally narrows and tightens around the big consolidated systems. The independent options, which are often the cheaper, more conservative options, get squeezed to the periphery.
They get pushed out. It's almost more insidious than the Iowa plan. Because with the Iowa plan, you had a clear villain. You had Robert Throckmorton. You could sue him.
Who do you sue now? The algorithm, the actuarial table.
You can't sue the balance sheet. It's just market forces.
Yeah.
But the end result is a structural restraint of trade. And there's one more layer to this that is just a perfect example of how this works. It's the statutory legacy of Medicare.
The 800-pound gorilla of American healthcare.
Medicare sets the tone for everything. What Medicare decides to cover, private insurance tends to follow. Now, under federal law, chiropractors are defined as physicians. That was a huge legislative win for them decades and decades ago.
But there's a but.
There's a huge but. The law, which dates back to the early 1970s, says that Medicare will only pay for one single thing a chiropractor does.
And that one thing is?
Manual manipulation of the spine to correct a subluxation.
That's it, just the adjustment.
Just the adjustment. Medicare does not pay for the examination to figure out what the problem is in the first place.
Wait, stop. How does a doctor treat a patient without doing an exam first? That sounds like malpractice. You have to examine the patient before you treat them.
You absolutely have to do the exam. Legally and ethically, it's required. But the chiropractor has to charge the senior citizen patient out of pocket for it.
So the treatment is covered, but the diagnosis isn't.
Correct. And Medicare also doesn't pay for the X-ray to ensure it's safe to treat. It doesn't pay for the therapeutic exercises to strengthen the area and prevent it from coming back. It doesn't pay for massage or traction or any other modern musculoskeletal care.
So imagine explaining this to an 80-year-old on a fixed income.
It's an impossible conversation. Mrs. Jones, good news. Medicare covers your 10-minute treatment today, but you owe me $150 cash for the 45-minute exam we just did, because Congress hasn't updated this statute since 1972.
She walks out the door and never comes back.
She walks out. And where does she go? She goes to her primary care doctor or to the ER, where Medicare pays for everything, the exam, the x-ray, the MRI, the opioid prescription. Even if that pathway cost the taxpayers 10 times as much as the chiropractor would have cost.
That is the ultimate unintended consequence. We are actively incentivizing the most expensive path because of a legislative glitch from 50 years ago.
It's a zombie law. The rationale for it is dead, it's completely outdated, but it's still walking around eating brains. And it reinforces this systemic idea that conservative care is some kind of luxury or an add-on rather than the primary entry point for spine pain.
So let's zoom out and put a bow on this. We have gone from containment and elimination, the spy thriller, to consolidation and benefit design, the economic thriller.
And the contrast is just so sharp, isn't it? The Wilk era was about professional equity, the basic right for the profession to exist. The modern era is about market function, the right for that profession to compete on a level playing field.
And the incredible irony is that the evidence debate, the thing they fought about for all those years, is basically over.
Right. That's the real tragedy here. We are not arguing anymore about whether chiropractic is quackery. Major clinical guidelines from the CDC, from the American College of Physicians, even from the FDA, they all say the same thing for most back pain. Start with non-drug, non-surgical care.
So that means things like spinal manipulation, exercise, massage, yoga.
All the conservative stuff. Science is settled. It says go left.
But the payment model, the architecture of access says go right toward the more invasive, more expensive stuff.
That is the most concise summary of American healthcare for spine pain I have ever heard. We have built a machine that is perfectly designed to ignore its own operating manual. We know what works conservative care first, but we don't know how to pay for it without disrupting the very lucrative revenue streams of these massive consolidated health systems.
It really reframes how I look at my own insurance card. I always just assumed the copays and deductibles were, just math. Just some random numbers an actuary came up with.
They are math, but it's math with an opinion. They are steering mechanisms. And right now, in many cases, they are steering people away from the very care that the evidence says they should start with.
So what's the final takeaway here? If I'm a patient or just a listener trying to make sense of this maze?
I think the takeaway is a healthy dose of skepticism. When you are being steered toward a particular treatment, especially an expensive one, ask yourself, is this the best clinical path for me, or is this simply the path of least economic resistance for the system I'm in?
And ask why. Why is the copay for the surgeon $40 and the copay for the chiropractor $75? There's a reason for that design.
And maybe, just maybe, you realize that the architects of access aren't men in smoke-filled rooms anymore. They're actuaries and benefits consultants, and their barriers are much harder to see, but they can be just as high.
The no chiropractors allowed sign is gone.
It's been replaced by a high-deductible plan sign. And for many patients, the result is exactly the same. They don't get the conservative care they need at the beginning of their journey.
This has been a fascinating, if I have to say, a slightly depressing look at the plumbing of our healthcare system.
Well, it's better to know how the plumbing works than to just stand there getting soaked while it leaks.
That's a fair point. That's it for this deep dive. Thanks for helping us decode the journey from the conspiracy to the spreadsheet.
It was a pleasure.
And to our listeners, thanks for being here. Check your explanation of benefits, question your copays, and we'll see you on the next deep dive.
What began as a documented strategy of containment and elimination ended in a federal injunction. The boycott fell. The barriers did not disappear, they evolved. Today, exclusion rarely announces itself. It is embedded in copays, in network design, in reimbursement policy, in statutory language that has not been updated in decades. The sign is gone. The architecture remains. Clinical guidelines are clear. For most spine pain, conservative care should come first. Yet payment models often incentivize the opposite. That tension is not accidental. It is structural. Professional autonomy requires professional participation. If you practice in Pennsylvania, stand behind the infrastructure that protects your license, your scope, and your reimbursement environment. Join the PCA. Support our PAC. If you practice outside Pennsylvania, support your state association. Engage your local workforce board. Policy and payment are shaped at the state level whether you participate or not. Organized advocacy does not fund itself. It does not sustain itself. It is built and defended by the professionals who choose to stand behind it. To those listening across state lines and beyond, the reach of this conversation continues to expand. Access design, reimbursement structure, and workforce policy are not local issues. They are systemic. If this episode challenged you, share it with a policymaker, a hospital executive, a workforce leader, or a colleague who needs to understand how access is engineered. Until next time, stay engaged, stay accountable. We'll see you on the next Deep Dive.